So this is a pothole technique for residents. Have a mental picture where you place your side port and make sure that you visualize the tip of the cannula into the anterior chamber before injecting anything into the eye. And then, always stabilize the eye when doing wound construction and your main incision at least 60 degrees away from your side port. Utrata forceps are used to grab the folded capsular flap. Once the flap is grasped, the flap should be carefully torn tangentially, always keeping the flap folded over, such that the underside of the capsule is always facing up. Use the wound as a pivot and open your forceps only when you are about to grasp the capsule. Otherwise, keep it closed to prevent pressing down on the posterior wound lip, resulting to egress of the viscoelastic out of the wound and shallowing of the anterior chamber. Next is to do a careful hydrodissection, wherein you will see a fluid wave behind the cortex. Forceful injection can lead to the nucleus to anteriorize outside the capsular bag. You need to rotate the nucleus carefully without zonular stress. In the Phaco pothole technique, you create a pothole deep enough to have a ledge for counter forces of your instruments. As the cataract gets harder, then you make deeper and wider potholes. So after making your pothole, you should carefully insinuate your Vernius chopper under the anterior capsule towards the lens equator. You may also use the anterior lens capsule as a guide, then slip down the chopper towards the equator. There should be an equal force between the Vernius chopper and the Phaco probe when doing the horizontal chop of the initial crack. The chopper and the probe should meet towards each other, then apply opposing horizontal forces to crack the cataract. There is no need to have a full crack. Even if it's just a half crack, you can still have a successful removal of the cataract quadrants. The Phaco pothole's beginner's usual learning curve is wrongfully placing the chopper superficially and as a result leads to unsuccessful cracking. I teach the resident to impale the cataract first and pull the cataract centrally so they can visualize the cataract's equator and successfully place the chopper behind it. Eventually, when they get used to placing the chopper in the correct position, they may do the dry chop like I usually do. So the instrument should not distort the eye and should not move the eye or distort the wound. The beginning resident often pushes the eye towards one side, making visualization difficult. The incisions should serve as an oarlock about which the instrument should pivot. So this one in INA, aspirate the cortical fronts under the anterior capsule. Spatial awareness is very important. You should always visualize where your instruments are inside the eye. And then you inflate the capsular bag with your cohesive gel. And injecting the IOL bevel down cartridge to make a tight seal, and make sure you don't accidentally pull the inserter out of the wound during IOL insertion. I always tell the resident that Phaco is an elegant surgery. They should be relaxed and calm. Thank you very much for watching.